Greetings, class. Steve Cole here again, and this is Parm 223, Unit 10, and today we're going to discuss Guillain-Barré syndrome, or Guillain-Barré, depending on how you want to pronounce it. And I think that this lecture will be short enough. We'll do it in one session. We'll see how it goes. Okay, so let's get right to it. I want to kind of give you a little background. Well, I got a couple cases. We'll do some cases first. So we have two cases here. Case 1 is a pediatric fall patient at a private residence. The patient's a 7-year-old female patient. Mother states the patient fell while stumbling down the hallway. The patient has no known significant history, had the flu a few weeks ago, but no known trauma, but now describes that both her legs feel funny, tingling, and numb. She has some coarse movement, but you notice that when she walks, she has some foot drop, almost like you'd see with some sciatic injury, but on both sides, and some foot slap. So she walks so that her tarsals and her ball of feet kind of slap a little bit as she steps. So let that settle in for a minute. Case number 2, you're dispatched for an adult patient with back pain and lower extremity numbness. No known trauma. But he did go to pick something up and heard a pop with sudden onset of pain. He's seen day 2 with back pain at the ED. He's given NSAIDs and discharged. Smokes, drinks occasionally, had the flu a few weeks ago. Calls for EMS on day 3 of difficulty ambulating and with numbness and tingling in both legs. So the question is, what do these patients have in common? Well, if you paid attention to the beginning slide, you might have what we call a clue that this is not your normal back pain and fall pain, but rather something that both these patients have called Guillain-Barré syndrome. So, what we're going to do is talk a little bit about the pathophysiology of it. We're going to talk about the definition of it. We're going to talk about GBS as an acute presentation, the challenges of identifying it, and discuss pre-hospital considerations. So let me tell you, this entire class has been a large part on things I wish I'd known as I had graduated paramedic school. And this was actually something I did know, but by random happenstance. I was in the pediatric ER at Vanderbilt University. They have a pediatric ER there. It just opened up back in the 90s. I was doing my clinicals. And they were also a children's hospital. So this 7-year-old girl came in who had described and documented ascending paralysis. And over the course of 12 hours, she was my primary patient along with the nurse, and I got to mark the dermatomes as her paralysis ascended up her legs and try to comfort her, and eventually I believe she ended up on a vent for a period of time. Now, when she had come to us with a presumptive diagnosis of Guillain-Barré syndrome, and when I asked what the heck that was, the nurse, the nurturing mentor that she was, reached over, pulled off a textbook of pediatric neurology, part 1 of 2, that was about 2,000 pages thick, and I'm not exaggerating, 2,000 paper-thin pages thick. It was huge, probably weighed 20 pounds, and slammed it on the desk and said, "It's in there somewhere," and went on with her day. Now, hopefully, your mentor, your preceptor does better than that. Hopefully he hands you the mouse and says, look it up, because today we have the internet to find these things out. But back then, we had these huge, monstrous textbooks. So, Guillain-Barré, I spent all day comforting her and reading about it in between. And it was an eye-opening experience. And the interesting thing, the reason why this matters to you guys, is there's been probably at least a couple times a year, if not more so, where I've encountered a patient that's had Guillain-Barré syndrome who just assumes that nobody has ever heard of it, knows what it is, and you're able to provide them some comfort and discuss with them. And sometimes it's a cause of their issues, sometimes not. So we'll just move right along. So what is Guillain-Barré syndrome? So it's an autoimmune disorder, loosely classified as an autoimmune disorder, that affects the neurological system. rather than a primary neurological order. So it seems to be associated with like many autoimmune disorders, with kind of a flu-like presentation a few weeks before it has its onset. Now, it's pretty rare, but not uncommon. It's not one of those things you'll see maybe once in your entire career, if that. Instead, it's something you will see if you work in a decently busy system. You'll encounter patients that have this in a history every so often. Not a lot, but every so often. And it's really unique in that it presents with ascending neurological weakness or paralysis. So it starts at the toes and marches its way up. And in some cases, severe cases, it results in respiratory paralysis and they have to be intubated. And then it tends to recede anywhere from a month to a year later. Now, about 1/3 will be that severe. Mortality is about 3 to 10%, usually due to cardiovascular respiratory complications. So they develop a ventilator-associated pneumonia or something along those lines. And it has lifelong disability. And about, I'm so sorry about that, about 10 to 15% of the time. One of the key things is that early recognition teams and treatment, getting to a tertiary care facility, tends to have a pretty good effect on their, not so much on the course of treatment, but the quality of care that they get, and if they develop any early adverse sequelae. So there's no sure diagnosis for this. Or diagnostic tests. There's no like Guillain-Barré metabolite you can test for or something like that. It's a diagnosis of exclusion, but it's pretty unique in its class. So we've known about it for a while. It was first described in 1859, where this gentleman had 10 patients with 3 distinct presentations, most with ascending paralysis. That's why its first name used to be, instead Guillain-Barré syndrome, was Landry's paralysis. One of these he cured with leeches, allegedly. You don't want to know where he put the leeches, trust me. But it was described again in 1916 by French doctors Guillain-Barré and Stroll. And incidentally enough, in 1916, 1917, 1918, you'll notice there's something very unique, is that 2 of these had French names and one of them had a German name, and that was right at the beginning of World War II, or right during World War II. So as this disease became more well known, poor Dr. Stroll got left out of the glory, and it just became Guillain-Barré syndrome. Anyway, multiple papers, multiple studies on this, and eventually identified the pathology as unique demyelination due to, or distinct ascending paralysis due to demyelination of the spinal cord. If you recall, we'll talk about the myelin sheath, but became dysfunctional demyelination. Now, it really became kind of well known in the 70s after we had a really bad flu season. And some people say it's the flu vaccine, some people say it's the flu, but it certainly is true that this predates the flu vaccine, so take it for what it's want. Take it for, conspiracy theory or not. So, now, why is this important? What can strike at any age are the most common in the elderly. But as I mentioned in my story, I saw it in a young pediatric patient. It's usually associated with infectious outbreaks, which incidentally we're in the middle of now. Now, I haven't seen, and I really should probably look it up, I haven't seen anything that says it's more common with influenza versus something else, so I'm not saying we're going to see a spike of this in a few months, but it would just be sauce for the goose, wouldn't it? So the most common initial presentation is weakness, difficulty walking, and abnormal sensation in the lower extremities. That's the most common presentation for ED and EMS visits, and in instance about 2 to 4 per 100,000. So that means in the United States, there's 80 to 160 new cases of Guillain-Barré syndrome each week. So it's rare, but it's not, or it's uncommon, but it's not super crazy rare. Now, the biggest problem is diagnosing. As I said, it's very difficult to diagnose. It's a diagnosis of exclusion. And usually only after they get to a tertiary care facility and they require intubation, so on and so forth. As EMS providers, we may be required to take care of these patients during transport, after transport, or in the course of interfacility transport after they're intubated, or maybe even years later as they're out in the community again. So again, we talk about the myelin sheath. That's the gray sheath that surrounds each neuron. And incidentally, in between, or in this myelin sheath, there's little nodes, and these nodes are called nodes of Ranvier. And the more you have, the faster impulses travel. So in a nutshell, when we have demyelination, we have distorted and slowed impulses traveling back and forth, efferent and afferent. And this results in abnormal sensation, weakness, and even paralysis of that nerve tract, of that dermatome. And what this ends up being, and we don't have a clear idea why it always starts at the feet that far down, but as it marches right on up, boom, 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 that's when it becomes readily apparent. Now, in the case I mentioned, the initial presentation was she kept falling into walls and walking funny and said her feet felt funny, which, when you have a 6 or 7 year old, can be a lot of different things, and sometimes we don't take it seriously, but there you go. So, as I talked about, the classic presentation was preceded by an infectious assault. This was documented in 2/3 of patients, 1 to 3 weeks prior. And usually respiratory or lower GI presentations are the most common presentation. Now, they have identified some common agents, gastroenteritis in some of them, viral influenza, hepatitis, HIV, etc., a wide variety of stuff, and occasionally vaccinations. Now, there's a couple cases of associated rabies vaccinations, a couple of them are some dubious relations to influenza. Now, I will say, if you're thinking about holding off on rabies vaccinations when you get bit by an infected animal, don't. Rabies has a 99% mortality rate. The vaccines are truly life-saving, so I'll just put that little plug in there. Rabies is one of the most, has the highest case fatality rate of any disease. The good news is you have quite some time to get vaccinated after the fact. So, a little sideline there. So the theory is that this infectious assault by these wide variety of organisms that have very little to do with each other causes an immune activation with autoantibody production, and basically these antibodies attack the myelin sheath and destroy it. Some of these patients even require pacing because the 10th cranial nerve is demyelinated. Now, you tend to see peak symptoms in about 4 weeks. So this is a gradual onset, and I think that's the other thing that kind of slows down diagnosis, is people might think it's sciatica, or they might think it's something else, or just, if it's in the very elderly, maybe they're just falling because they're elderly. But these symptoms are always neurological is what they present as. And they're bilateral. So that's one thing that sets it apart from sciatic pain, is that it's bilateral instead of unilateral. Stuff of that nature. So we talked about ascending symmetrical paralysis, ascending symmetrical paresthesia, and weakness. We also get visual disturbances, and we'll talk about that in a minute. The ataxic gait is from the early stages of the weakness. They also have facial and ocular motor weakness. So this is, you remember when you had to learn all those cranial nerves? This is where understanding those comes into play, because you get demyelination of the cranial nerves, and they manifest themselves by understanding where those cranial nerves go. Now, about 15%, will only have motor deficits, no sensory deficits. We really don't know why, but the ascending paralysis is always along the dermatomes, so you have to know those. Now, sometimes you hear the term paresthesia, and sometimes you hear the term dysesthesia. And dysesthesias are burning or shocking pins and needles, like when your leg has been asleep and it wakes up. And it's present in about 50% of cases, particularly in the lower extremities. And unfortunately for some, it'll persist in about 10% of patients after they're done with the Guillain-Barré syndrome and they've otherwise recovered. 50% will also present with significant back pain or lower extremity pain. But they can have pain in other locations as well. It's described as aching and throbbing, and I can easily see how this can be confused with, oh, I twisted my back. So as the paralysis proceeds, or the weakness proceeds up the body, what you see is they lose their muscular recruitment for work of breathing. So as their abdominal muscles get weakened and paralyzed, they develop exertional dyspnea, shortness of breath. Depending on where if it's any of the cranial nerves that are affected, you may have difficulty swallowing and slurred speech. And this can be easily mistaken maybe for a stroke, and that should always be one of your rule-outs. But again, this will be accompanied by these weird lower extremity presentations that you wouldn't normally see with strokes. Now you also, because of its effect on the parasympathetic nervous system, will see autonomic instability. So you may see diarrhea or constipation, urine retention. You may see bradycardia. You may see them being really profusely diaphoretic or completely dry. So it goes back and forth, and facial flushing, which you see some of this. If you remember, we talked about autonomic dysreflexia. This is an autonomic instability. They'll fluctuate back and forth. So when I talk about the ataxic gait, this is a demonstration of that, and you should be able to click on the link if you can't see it here, but this is a demonstration of what an ataxic gait might look like.
The ataxic gait, the patient has difficulty narrowing the station, maintaining balance. So typically they'll have a wide stance, is trying to maintain balance, and that there oftentimes will be unsteadiness in the trunk. So there may be some truncal titubation, which is an anterior posterior tremor at about 3 hertz. And there's also a tendency to lunge or to jerk sideways, and the patient then has to catch themselves. Of course, one of the ways to bring out this particular type of problem is to narrow the station, asking the patient to walk tandem. So if I then am ataxic, I then try to walk tandem, then I'm going to have difficulty walking.
As you can see there, that's, you can see how perhaps we might be called for a possible intoxicated patient or something along those lines who has difficulty walking in that fashion. Again, shows why not everything is as it appears. So I talked about ascending. I talked about knowing your dermatomes. These are your dermatomes as they come off your spinal cord, and you can see them there. So this is why sometimes when you see these patients, this is true not just of Guillain-Barré, but any spinal cord injured patient or suspected spinal cord injured patient, is what I like to do is sharp dull differentiation, where you'll take perhaps your pin and your the dull part of it and the pointy part of it, and you'll ask a patient to tell whether it's sharp or dull with their eyes closed, on right and left sides, and moving up and noting if and where they have difficulty determining that, and marking that with a marker, and putting a date and time on it. Because if in an hour it's ascended from that, you have documentation, and that gives them a head start on diagnosing it. EOM's assessment is something else, extraocular movement. So we have adduction, abduction, elevation, and depression, etc. You see some examples there. Now, the reason why this is important is sometimes if you think about the cranial nerves again, how many of them, cranial nerve 3, cranial nerve 4, and cranial nerve 6, have to do with extraocular movement? So, sometimes when you have cranial nerve demyelination, as opposed to peripheral nerve demyelination, you will have abnormal movement of your eyeballs. And sometimes you'll have double vision because they won't move in sequence, or there'll be a delay of one eye moving trying to catch up with the other. Now, again, this is part of getting a very good, high-quality assessment and assessing this. And if you don't know to look for it, you won't know to document it. So what's the prognosis? Well, about 25 to 30% require mechanical ventilation, either in the acute, as in the first 24 to 30 to 48 hours, or subacute phase. 10% will get better, then deteriorate again about week 6 to 10. And imagine this, somebody had some ataxia, they got better, they never went, or they were misdiagnosed, and then they take a sudden decline. 20% will be unable to walk after 6 months. As we talked about 3 to 10% will die. The faster the progression, the worse the prognosis. So the worst of the worst will be the ones that are going to try to deteriorate within the first 24 to 48 hours. So what's your treatment? The number one treatment absolutely is going to be assessment and recognition. So this is a case where you might have a strong suspicion and say, instead of taking you to the freestanding ER, we'll take you down to the main campus, something along those lines. Airway support is pretty self-explanatory. If they have severe or progressive respiratory distress, we can make those decisions. Occasionally, we'll have these fluctuations in heart rate associated with this, and that's from the 10th cranial nerve being demyelinated. If they have orthostatic hypotension, well, then it's fluids and keeping them supine. If they have hypertension, some places use esmolol esmolol infusions or metoprolol. Analgesics will not be effective for this, for their pain if they have that. Now, once they get to the hospital, this again ties back to some of our earlier lectures. If you're doing a transport, they might have actually done plasmapheresis. Now, plasmapheresis is a bit like dialysis in that they filter blood through, but what they do is actually remove the plasma, and of course plasma is where antibodies are, and then they will administer fresh plasma, not the patient's own plasma, but they'll replace the plasma with donor plasma. So you may be doing that, and that actually has shown pretty significant improvement in patient care. It has shown a 50% reduction in time to recovery as well as total recovery time, and it's relatively easy to administer. So there you go. Sometimes immunoglobulin has been administered as well, and it's also been relatively comparable to plasmapheresis, and there's also some cases where people have received both. So some of these patients, if they've had Guillain-Barré for a while, again, this goes back to our earlier lectures, may require trach care. They may be still in a vent. They may require quite a lot of comfort and psychological support, especially if this is very new in their course, because it can be absolutely terrifying. Another thing to keep in mind is they also require prevention of thromboemboli, so that may be in the course of special TED stockings or whatever. It may be requiring for you to move them. If it's a long transport, shift them from the side to side, stuff like that. So, I've got a couple of videos up here that you can click on. So you're thinking, how will I click on the video? Well, I've put the PDF of this in the show notes, so you can click on there. One is of a firefighter paramedic who had said ONCIV GBS. So there's great examples of the ataxic gait with that one. Another one is a case of a young lady named Delilah Boggs. And I think you'll like both of these. Go ahead, give them a watch, and come think of it, I think I may try to post these as videos so you can watch too. And that's it. Are there any questions? Post them in the forum, and thank you for your time.